Today, I'll be just discussing one image-based question today, a single MCQ, and I'll also be explaining about the options that were probably given. So, by and large, the consensus was that this sort of image was given. This is from Dr. Nirmalya Banerjee from the LinkedIn. So, your options were spot the diagnosis in this colonoscopic image. They usually just don't throw an endoscopic image at you without telling you the part involved. Whereas for a CT and an X-ray, they will not tell this is X-ray of the chest. But for an endoscopic image, they usually tell you whether it's the large intestine, small intestine, the esophagus, or it is in the abdominal cavity like your laparoscopy or your cholangioscopy if you're inside the bile ducts. So that's very important. They usually do mention, or a bronchoscopy. So the options were they have committed that this is a colonoscopic image. Even if they did not commit, they will give you answers which are belonging to the colon. So you know it's a colonoscopic image. So it's colonic polyps or a CA colon or a pseudomembranous colitis or a colonic diverticulum. Now I can just keep this and tell you that this is pseudomembranous colitis. The next question that will be dragging on in the student's brain will be, how do colonic polyps look vis-a-vis this? How do CA colon look? How does colonic diverticula look? Now, with this question, you use this as a template and look at the other pictures also with this. These things will stay in your mind better. Instead of individually seeing colonic polyps, individually seeing CA colon. So let's go to the next slide. So let us see one by one. We'll have a look. I didn't want to put all the images in one slide. Students tend to go ahead of me and unnecessarily they are wasting their time. So coming to colonic polyps, this is from Dr. Thomas Alexander. He was a gastroenterology colleague in PIMS. How do they present? They will present with mostly bleeding. If you know the finding or the clinical symptomatology, it's easier for you to pick up a finding on a scopy. And usually they give it in the stem. So it will be much easier for you to pick it up, because more than ever, a clinical presentation or a clinical clue is very, very important when you're looking at an image to make a diagnosis. So the main thing will be bleeding in polyps. They will be pedunculated. You can see the peduncle there. You can see the pedunculated. See, the summit is so big and the peduncle is so small. See the peduncle. Fine. Mucosa will be smooth. See the mucosa is smooth here. So this is a colonic polyp. Let's come to the next slide. Is it a CA colon? One of the options. This is from Dr. Vijay Raghavan, again from PIMS. Here, the main thing will be bleeding, or constipation is a big clue, or it can be plain tenesmus. More than bleeding, they will have constipation and tenesmus if it is lower down, say like in the lower sigmoid or in the upper rectum. Tenesmus is a feeling of incomplete evacuation. So these three will be most important in the history. And what will you find? You will find an ulcero-proliferative growth. Can you see the ulcer here? Can you see the ulcer here? And there will be lot of bleeding, friable. You can make out the tissues friable and bleeding points will be there. Unlike a smooth mucosa here. This is the difference. And this was not ulcero-proliferative. It was just a polyp. But here it is ulcero-proliferative. See that irregular growth. See? Can you draw it? See? Huge growth here, irregular. It has ulcerated in places. You can see the lack of continuity. It has again ulcerated here also. and you find very friable and bleeding tissue here. See. So that's how you differentiate CA colon from a colonic polyp. And when they give you imagings, they will give you classical imaging. You need not break your head. And always look if you can find a clue in the stem. Coming to pseudomembranous colitis, this is from Dr. Nirmal Banerjee from Calcutta. The main thing patient will have is a diarrhea. And most of the time, the stem will be taking you to an ICU setting. He may be admitted for a head injury, or for a thoracic injury, or for a diabetic ketoacidosis. But it will invariably take you to a sick patient in the ICU setting. And most important, the word antibiotic will be coming most of the time in your stem. If they don't use the word antibiotic, they will be taking you to a sick patient in the stem. Whereas here and here, they may not take you to a sick patient. These are the clues that will help you catch your images. Now, you will find whitish membranes that can be lifted off easily on insufflation. The moment you put air and inflate the bowel for better visualization, some of these membranes will be very flimsy and they will come off the mucosa. What is the last one? Colonic diverticula. This is from Dr. Bharat, again from PIMS. They were our colleagues when I was working in PIMS. Colonic diverticula, the main thing will be pain. Look at the main problems here. It's bleeding, diarrhea. Here it is pain. It will not have diarrhea. They will have constipation. Because the distal pressures were high, because of constipation, proximal diverticula will develop because the force is so much that the mucosa will get forced out through the muscular layer and you can find these mouths opening. So most probably they will tell either pain in the left iliac fossa because diverticula are more common on the sigmoid and descending colon rather than the cecum. So the main problem they will tell pain or bleeding, but they will never ever use the word diarrhea. They might even lead you with a constipation. So you can see the mouths of the diverticulum and here there is a close-up of the mouth of the diverticulum. So thank you all very much. Next time, I had only time to put up this slide today, but tomorrow hopefully I will take you a little deeper into pseudomembranous colitis. Now pseudomembranous colitis can even be so bad that it leads to a laparotomy. So I will bring you one case capsule and we will talk about pseudomembranous colitis, the risk factors, where do you suspect them and what can you do for them, the spectrum of presentation and what can you do for them. Thank you very much. As usual, I will ask you to subscribe, share and like and also my Telegram channel. There are lots of views, but they are somehow not getting into subscription rates. Please do look into this. Please subscribe. Thank you.